Good evening, everyone. Today's topic is hematological management, and the faculty that we have here is Dr. Shraddha Patharkar, ma'am. She is the associate consultant at ABMH Pune. Thank you, ma'am. You can start.
Yeah. So we have covered majority of hematological topics. So the only two topics were remaining, out of which one will be actually included in oncological emergencies. But I'm covering it today because I have only two topics today. Rest two topics in hematology like leukostasis and hyperviscosity syndrome. Again, those become a part of oncological hematological emergencies. So I have not covered those, but I'll just tell you the salient points that you need to read about. So and I have only two questions, but through theory, what kind of questions they might ask you in the exams, I can just uh, will put focus on those things. So we'll start with the first case. 22-year-old female got admitted with fever, cough with expectoration, breathlessness. She got treated for severe community acquired pneumonia in critical care. Despite cultures getting negative and repeat cultures didn't find any organism, she continued to spike fever and organ dysfunction persisted. Her CBC showed persistent leukopenia and thrombocytopenia. So dengue malaria panel was sent, which was negative. Imaging done for source identification. CT chest, there was resolving pneumonia patch as compared to the previous scan, and CT abdo-pelvis showed hepatosplenomegaly. Hemat reference was given for her persistent bicytopenia. Uh, uh, the hemat team did bone marrow study on the patient, and hypercellularity with the hemophagocytes was the finding. Which of the following is true statement regarding this case? Macrophage activation syndrome is HLH in rheumatological disease. We call it as HLH in rheumatological disease. We call it as a macrophage activation syndrome. Malignancy associated HLH has the worst prognosis. H score is used in adults to diagnose HLH. Uh, Steroids or immunosuppressants is the mainstay of the treatment, and HLH mimics septic shock with multi-organ dysfunction, as in our case, and all are true. Can anybody tell me the which of the following is a true statement out of six?
All are true.
Yes, all are true. Uh, See, because we know this is the hematological domain, but you cannot diagnose HLS in your first uh, patient's impression. So they pertaining to our case, it looks like septic shock with multi-organ dysfunction, and we are not able to find out the source of infection. So despite patient getting treated for underlying infection or sepsis, and the fever is not settling down, or sometimes when patient presents with fever of unknown origin and presents with bicytopenia, hepatosplenomegaly, all these clinical points as well as some lab features will point out it might be HLH. So there are HLH mimics, septic shock is one of them. So you have to keep that in mind. So what is HLH? It is a fatal disorder characterized by dysregulated activation of cytotoxic T lymphocytes, natural killer cells, and macrophages. So all these immune cells, they get activated, they produce hypercytokinic response, and there will be, because there's cytokine storm like picture, like in COVID patients, the way we used to get cytokine storm, that storm is mounted, and then immune mediated injury to multi organ happens. So it's HLH is a it's an emergency situation, and it's a if not treated, it has a poor prognosis. Diagnosis is difficult because of its diverse manifestations and the clinical presentation, and there are many diagnostic mimics. just now told you that septic shock, or sometimes liver dysfunction, because here the liver enzymes will be deranged. Many a times dengue shock syndrome, uh, they may develop HLH, or dengue shock syndrome itself can mimic like HLH. So there are many instances where you cannot differentiate between the infection and the HLH. Recognition of hemophagocytic histocytes is the key component of diagnosis, but again, it's not the specific criteria. HLH 2004 protocol used for pediatric population, also used in adults, but it's not validated. So we, for adult diagnosis of HLH, we use HS score. So that is a online uh, web scoring system. It has 9 parameters which predict whether patient has HLH or not. So which are these 9 parameters? The presence of immunosuppression, fever, organomegaly, either hepatosplenomegaly, elevation in triglycerides, ferritin levels, AST, ALT levels will be elevated, more of a ALT, and fibrinogen levels will be low, presence of cytopenias, so at least 2 cell lines will be suppressed, and hemophagocytosis in the bone marrow. So there are these 9 components. You put numbers, and each criteria is assigned some value, and a higher score corresponds to higher probability of HLH. So, and the cutoff to diagnose, optimal cutoff is 169. So this is the online web calculator that is available, and we use this for adult HLH diagnosis. So what is primary HLH and what is secondary HLH? So primary is familial. It is because of some your genetic mutations affecting your this cytotoxic T cells and NK cells. So mostly they present early in life, most within first year of life, and they are dreadful. I mean, the prognosis is much worse, and they, because it's a primary, associated many immunodeficiency disorders are also there. But in adult, what we get is secondary HLH, and most common cause for the secondary HLH is infections. Second most common is malignancies. Hematological malignancies lead to HLH more than the solid organ or any other non-hematological malignancies. Rheumatological disorders, many autoimmune disorders, drug hypersensitivity reaction, this DRESS syndrome, uh, then hematopoietic stem cell transplant, graft versus host disease reaction. So all of these can lead to secondary HLH, and the treatment of HLH is immunosuppression, because now this your immune system is hyperactivated or dysregulated. So you need to suppress this immune system. That is the mainstay of the treatment. And incidence is not that uncommon. It's 1 in every 2000 adult patients admitting to the tertiary care hospital. So you have to keep this in mind to rule out HLH when your patient is not getting better and your patient's fever is persistent and cell lines are suppressed. So you have to think about this. Then EBV associated familial HLH is also there. In secondary HLH, it's when many a times when patient is on chemotherapy or some immunosuppressants, and this EBV reactivation might happen, and that can cause HLH. Cytokine storm of HLH mimics COVID-19 infection. Most common cause, again, uh, in Indian setting, it's infection, but second most common being malignancy, and is associated with malignancy associated HLH has a worse prognosis because it has a very rapidly deteriorating course and high mortality rates. HLH associated with rheumatological disorders, connective tissue disorders, we call it as a macrophage activation syndrome. So that term, macrophage activation syndrome, is HLH in rheumatological conditions. It's not for non-rheumatological HLH. So HLH responding to immunosuppressive treatment, we call it as HLH disease. But when despite giving immunosuppressants, it's not getting better, then you have to label it as a HLH mimics. Clinical presentation, typically patient will have a high grade fever. 100 most of the times, more than 98 to 99% of the times, HLH patients have a high grade fever, more than 38.5. If not, then you have to question your diagnosis. But there are confounders. Maybe you are giving antipyretics, maybe patient is on ECMO or CRT ongoing, where there will be heat loss. So Apart from those cases, most of the cases will have high grade fever or non resolving fever. Cytopenias, again, in three lines out of three lines, thrombocytopenia is the first one to you might notice. Again, sepsis causes thrombocytopenia, so here whether it is HLH related or sepsis related, it's difficult to tell. Multi-organ involvement, when it may present as a ARDS lung. In heart, it may present as a myocarditis, reduced EF. uh, in kidney dysfunction, AKI. In CNS, patient may present as a delirium, delirious, focal neurodeficit, uh, posterior reversive hypertensive response, and press like features, seizures. In liver, it may present as just transaminitis, or may present as a fulminant liver failure as well. So HLH, dengue shock syndrome with HLH can present as fulminant liver failure. Then cytopenias, coagulopathy. Even these patients can present as a DIC, rash, petagy because of thrombocytopenia, organomegaly. Lymphadenopathy is not that common. If there is like multiple mediastinal or abdominal lymph node enlargement, you have there is a possibility of some other diseases rather than HLH. Then you have to rule out TB, histoplasmosis, lymphomas, because again these are also mimics. But again, lymphadenopathy is not very common with HLH. It's common with the chronic granulomatous diseases or some other lymphomas and all. So characteristic microscopic finding of HLH is, you'll get this hemophagocytes, but it's again not very specific. And these infiltrates, they may be seen in some other, like not always you need to do bone marrow study. Maybe this hemophagocytosis might be noted when you do biopsy of spleen, liver, lymph nodes, or some other sites like lungs, meninges. But again, many a times this patient have severe thrombocytopenia, so taking biopsy from these other sites is risky. And it's better to go for a bone marrow biopsy, because again, even with low platelets of 20,000, there is no need to transfuse. You can get bone marrow biopsy done at such low platelets. Infectious causes of HLH, they also increase your plasma cells, immunoblast, granulomas, and you can notice that also in bone marrow. So by doing bone marrow, you can rule out other infections and some other lymphomas or some myeloproliferative disorders sometimes, if you think they are mimicking your HLH like picture. um, Again, lab diagnostic criteria, serum ferritin is having it's very important. It has a negative predictive value, and the cutoff being 500. So your serum ferritin value, if less than 500 nanogram per ml, then it, according to HLH 2004 criteria, you can rule out HLH. But again, to diagnose HLH, I will show you the table, next table. You need at least 5 out of 8 criterias. So it's not just the single ferritin value will not diagnose it, but definitely it has a negative predictive value. uh, and most of the times in HLH, you have ferritin levels there, those are special in adults, they are quite high, even about 10,000 many a times. And higher the value, more is the sensitivity and specificity to diagnose HLH. And again, it in higher the value, it indicates poor outcome. So again, a high ferritin level, high hyperfibrinolysis with a high D dimer, drop in fibrinogen, prolonged PTINR. Again, lab wise hyperfibrinolysis, again this picture mimics like a DIC. So HLH may present as a DIC also. Activated lymphocyte release the soluble form of CD25. So here, because of this dysregulated response, your lymphocytes are activated and they will release this CD25. But again, this test is not available everywhere, and it takes some time for the report to come. So but again, it's relatively specific to diagnose HLH, a soluble CD25, raised soluble CD25. So this is your diagnostic criteria of HLH. Out of 8, 5 should be present. So fever more than 38.3, splenomegaly, cytopenias affecting at least 2 of the 3 cell lines, like hemoglobin of less than 9, platelets of less than 1 lakh, neutrophils of less than 1000, uh, hypertriglyceridemia more than 265 milligram per dl, sorry, low fibrinogen levels less than equal to 150, hemophagocytes in bone marrow or spleen or lymph node or liver biopsy, low or absent NK cell activity, ferritin levels more than equal to 500 nanogram per ml, and soluble CD25 which is raised. So out of these eight, five should be there to diagnose it as a HLH according to HLH 2004 diagnostic criteria. But for adult, I have already mentioned this was actually designed for pediatric population, and we are still using for adult. But again, it's not very much validated, and we calculate HS score, which is an online web score, and that cutoff is 169. You have these 9 parameters. You put numbers in that, and if your number comes as more than 169, you can label it as a HLH. So again, I've already mentioned about this. In adult we have secondary HLH, infection associated, again, in any like bacterial, viral, parasitic, fungal infection can cause infection associated HLH. And why you need to know whether it is infection associated malignancy, not only for prognostication, like I have already mentioned, malignancy associated HLH has a poor prognosis because of rapid deterioration, but your treatment also differs somehow. For autoimmune diseases, like you need pulse steroid and cyclophosphamide maybe, and there are like interleukin antagonists for infection related, that we will see in subsequent slides. So you need to differentiate whether it is infection related, malignancy related, autoimmune disease related, transplant associated. Many a times it's graft versus host disease patient, uh, spiking fever, not getting better, persistent bicytopenia, you have to suspect HLH. Then drug associated, many hypersensitivity reactions, many cancer immunotherapy agents, drugs causing DRESS syndrome, they also cause HLH. So again, the commonest findings, as I have already mentioned, if there is no fever, it rules out, provided you are ruling out confounders like patient has received antipyretics, you are doing cooling measures, and that's why now there is no temperature, or maybe patient on ECMO or RRT, and that's why there is no patient is not spiking fever. But otherwise, 100% of the times there will be fever. Splenomegaly will be present in adults in 40 to 80% of the cases, hepatomegaly in 14 to 70%, neurological symptoms 9 to 25%. But again, when the patient uh, of HLH involves brain, like neurological symptoms, when he develops, you have to aggressively treat with the etoposide, not just the steroid. Dexa you can give, but uh, etoposide, which is actually a salvage treatment, many a times we use for the refractory HLH. But once the CNS is involved, the mortality is quite high. So you have to start early etoposide. That thing you need to remember. And miscellaneous, like maybe rashes, lymphadenopathy, lung involvement. But again, the commonest present findings will be fever, splenomegaly, hepatomegaly. So, in labs, commonest finding will be cytopenias. More than two lines will be abnormal. Maybe anemia, thrombocytopenia, leukopenia is less common. Mostly, it is anemia and thrombocytopenia in more than 85% of the cases. And triglycerides will be high in 22 to 88% cases. Fibrinogen will be low. Ferritin levels more than 500, it's there in 77 to 100%. So after cytopenias, commonest finding will be high ferritin level, which has a very high negative predictive value, because ferritin in sepsis also you'll get high ferritin level if patient is having dengue hemorrhagic shock syndrome, fulminant hepatic failure, or maybe patient has received multiple transfusions. So ferritin is not specific for HLH, but it has a negative predictive value. You can rule out when the value is less than 500. Elevated soluble CD25, again it's very specific, but it's like not available, or maybe uh, not test is not available everywhere. So hypoalbuminemia and abnormal renal function, elevated transaminases, again elevated ALT, AST, hemophagocytosis, and low absent NK cells. So these are like lab findings.